Good afternoon, everyone. Welcome to Grand Rounds. I have a little, it's actually an important notice, and I'm sorry, it's small on the screen right here, but hopefully you guys that are watching via Teams can see it. We have switched over to Cloud CME. Actually, Wright State and Premier made this decision. Wright State University does our credentialing for CME and CEUs at Dayton Children's. And so we are following suit. We are now with Cloud CME. I have been sending out numerous emails and notices. Please be sure and check your emails. I do plan to have an educational activity on it. It's just right now, I'm still in the early stages of learning. So I learn something new every day. Things are changing every day. So it's a brand new process. So please hang in there with me and give us some patience in the CME. I'm the coordinator and Dr. Matson is the director. Yes.
So when I put 195
It's wrong. You don't put the 1 first. See, I found that out. It is just 855-618-2034. Don't put the 1. I sent this out to everyone, but who knew? Some people, I thought that when I did it, I did put the 1 before it, but for attendance and evaluation for everyone that attends Grand Rounds, you have to create your account, which is right here. You're going to go into Cloud CME and enroll. And then once you come down to your educational activity, you can do it an hour before or up to 2 hours afterwards. You simply
when I did the 195, it said that my RN credentialing is not a credit type for this Grand Round.
that's for the evaluation, and that hasn't been loaded yet. So it's not going to show up yet. So the first thing that you want to do is to text your attendance for today. Those of you who need CME or CEU, you're going to text 855-618-2034. That's after you pair your phone with Cloud CME, which is step 1. Step 1, it tells you how to go in and make your account, okay? Then you have to pair Cloud CME with your cell phone. So how you do that is with your cell phone, you're going to text 855-618-2034. And then in the message line, you'll put your email address, whatever your email address is. First, if it's Dayton Children's, Shriners, your email address, that's what you put in the message line. That's how you enroll. So I know that there's going to be a lot of confusion with this. And again, we're just, this is the first Grand Rounds that's using it. Lucky us. So hopefully everybody won't have too many problems. If you do, just be sure and email me or call me. And my email address and my phone number is on this piece of paper. I would keep this handy in the beginning so that we can learn the process. As far as Grand Rounds next week, unfortunately the speaker had a conflict, so we did have to cancel that. But then we will be back on February 14th. So again, this Cloud CME, I know that there's going to be some questions and confusion, but keep this handy, this piece of paper, well, what I have up here right now, so that you can at least get your account, your attendance recorded, and then we'll be able to go and pull up the evaluations. Okay.
I have
Dr.
a
Madsen, I
question.
think,
Is
going to
195 going
yeah,
to be the
introduce our
code for
speaker
every
today.
activity?
So thanks for your patience.
Okay. I hope you don't mind. Dr. Madsen asked me to fill in today. I'm Peter Quill, but most people just call me Star-Lord. I don't typically get starstruck too often as a legendary outlaw and the retired leader of Guardians of the Galaxy, but today we have the pleasure of hearing from the woman, the myth, the legend, Dr. Irma Reyes. Now, some of you may be asking, hey, haven't I seen her somewhere before? And to that I would say, why, yes, you have. Particularly if you subscribe to Dayton Magazine and saw who graced the cover of the 2023 Best Docs of Dayton edition. I just so happen to have my signed copy with me. I'm told that Dr. Reyes is happy to provide her autograph for a nominal fee. The meet and greet autograph session will occur 5 minutes after grand rounds in the main lobby. But before that, let me tell you a little bit about Dr. Reyes. She completed her medical school training at Midwestern University, Chicago College of Osteopathic Medicine, and then went on to residency just down the road at Loyola University Medical Center. She completed her fellowship in child neurology at Children's Hospital, Los Angeles. We at Dayton Children's were lucky enough to steal her right out of fellowship in 2018, where she works as part of the Pediatric Neurology Service and is also an associate professor for Wright State Boonshoff School of Medicine. So please give a warm Dayton Children's welcome to Dr. Irma Reyes.
All right, thank you so much, Dr. Madsen. Thank you. Not sure how that magazine even happened, but there it was. And I'm sorry, I'm not dressed up or probably as entertaining as he is, so I apologize. But thank you so much for having me here. And so I wanted to talk about the excitement in the DMD world. So there's a lot going on in regards to treatment options and just new studies going on. So just objectives for today, we're going to just review Duchenne Muscular Dystrophy and its disease process. We're going to cite older treatments and the current ones as well, and then discuss the new approved treatments and those underway. No disclosures. All right, so case. So for those who have been here for the last 5 years or so, I have given similar lectures with similar cases. So you may see some repeats of these slides if you guys have attended those lectures in the past. So here's one case. And I do like to start my lectures with a case just so, you know, we are clinical based. This is also geared towards medical students and residents. So I just want to give an idea of the type of patient that we may see in clinic or that you guys may see in clinic and refer to us. So JP, he is a 5-year-old ex-full term adopted boy with a history of delays, both in motor and cognition, who came in for increased clumsiness and regression in walking. So adoptive mother reports that she had him since infancy, so she's not really sure about the family history, the biological family history. But from what she recalls, he was sitting and crawling on time. He was walking on time at 13 to 14 months of age, talking, a little delay 16 to 18 months, but he was overall doing okay and keeping up with milestones. However, over the last year, he had become clumsier. He was getting PT and OT in preschool because he was just quote unquote not up to par per mom with the other kids. He was starting to run slower than his peers, and he really wasn't just climbing as well as he used to. No known injuries, no joint swelling, redness, or other associated symptoms. And again, this was a gradual process over a year. So again, birth history, really no known complications, just the delays that we had mentioned in his past medical history. Only one hospital stay for dehydration secondary to acute gastro, no surgeries. Looking at his development, as we mentioned, he was walking on time. He did have some speech issues, as mentioned, difficulties with enunciation. Otherwise, really no other regression noted in his history. And his review of systems was otherwise negative. So when we took a look at him on the very first initial visit, general exam, BP was fine, pulse. However, looking at his growth curves, you can see that he's always been a little bit under the curve right here. But otherwise, generally speaking, he looked pretty good. So now focusing on the neurological exam. So mental status, he was a very active little boy. He was awake, alert, he was engaging, he was crawling all over the place. He could follow simple commands, but he was very easily distracted. But he was, in regards to language, he was speaking in short sentences, did have some difficulties with enunciation. Cranial nerves were all grossly intact. Focusing on the motor exam, so we had him with him being 5, he was able to do a lot of the confrontational strength testing. So pushing, pulling, all of those things. Looking at his bulk, he had pretty good bulk. However, when you lifted up his pant legs, he had significant calf muscles, well, it looked like calf muscles, if you will. And he had tone was normal throughout, no issues. He was pretty strong overall. He was appropriately resisting me. However, when I had him get up from the floor, he had to walk up his legs in order to get up. And mom said that that was new and progressive over time. Sensory was intact. Reflexes were all intact. Coordination was fine. When it came to his gait, when it came to just a regular walk, he looked really good. But when I had him run down the hallway, that's when you can tell that he was slower than you would expect for a patient his age. I wouldn't have called it waddling at the time, and there was no lumbar lordosis that we were seeing at that point. So due to the concerns for his regression, so you have this gradual onset over a year in a patient who have unknown family history, but his growth velocity is he's pretty small for his age and height and for weight. And then he's got his motor findings. And then when I talked about the calves, that's what we call pseudo hypertrophy. And I'll show you pictures of that in here just for a little bit. So there's a concern for an underlying neuromuscular disorder, specifically a muscular dystrophy. So we went ahead, and so for these patients that we see in clinic, we go right ahead to do baseline labs. Basically, we want to, if we're looking for muscular dystrophy, we're looking for labs that would show us findings of elevated muscle injury. So CK, looking at your CMP, specifically your LFTs, as that can be a reflection of muscle breakdown. CBC, just seeing if there's any other associated inflammation. You can also do inflammatory markers as well, and then other electrolytes, mag and phos. So his initial workup, so his CK significantly elevated to near 17,000. LFT is also significantly elevated. The rest of the labs that we had ordered were within normal limits. And so, of course, with those findings coinciding with his assessment and evaluation, we went ahead and sent him to genetics, and he was ultimately found. So we have we use the Invitae genetic company, and so they can screen a comprehensive neuromuscular panel, which does include your DMD gene. And so he was found to be positive, and I'll get into this in a little bit, but instead of a large deletion or duplication, which is the majority of our DMD patients, he was actually found to just have one pathogenic axon in axon 33. And then I'll explain why the genetic testing actually does become important over time. All right, so DMD. Not something that you typically see a lot, which is good, but it does happen in about 1 in 5,000 boys. And I think the most recent literature that I saw, which I apologize, I didn't correct, was about 1 in 3,300 boys. So it's the most common neuromuscular disorder in childhood. It's X-linked recessive. The gene is, so you have your dystrophin gene right here made up of 79 axons. So that is one of the largest. And so you have this gene on the X chromosome that's responsible for protein, your dystrophin. So what does dystrophin do? It helps to provide that mechanical reinforcement to the sarcolemma and stabilizes that glycoprotein complex. When there's any kind of mutation in that gene, whether a deletion, duplication, interframe reading issue, what have you, if there's a deficiency or absence of that dystrophin, then you have disintegration of that complex. When you have disintegration of that complex, then you have degeneration of your muscle fibers, leading to the clinical presentation of muscle weakness. And not only does that involve muscle weakness that you see when you do strength testing in your legs, your arms, but it also affects the muscles of your heart and your respiratory. So presentation, so you can actually start seeing symptoms at around 2 to 3 years of age. It is pretty early. We usually only see these actually with patients who have older siblings, because a lot of first-time parents may not realize that, oh, my 2-year-old is clumsy. That seems like a normal 2-year-old thing. So early on, or earliest that you can typically see is 2 to 3, but the average that we typically see in clinic is around 5 to 6 years. And that is because the kids are in school, they're starting to be in sports, they're starting to be compared, unfortunately, to other peers their age. And that's when parents and coaches and other people start to really notice the difference. As I mentioned earlier, it's a gradual onset. It affects your proximal bilateral lower extremities first, and then it involves your distal muscles in your upper extremities. You can evolve into a waddling gait, some toe walking to compensate for that weakness. You have difficulty with climbing stairs because of that proximal weakness. You can have decreased endurance, and then you can have muscle pain and cramping. You can form lumbar lordosis or scoliosis, as well as the calf pseudohypertrophy that we mentioned. And you can also have some learning issues, attention issues, or other cognitive issues. The general exam, so this patient was the bread and butter of DMD patients. So you would see slowed growth velocity and short stature. The cardiac, pulmonary, and the orthotic issues really don't come in until later on. Neurological exam, really the big thing that we're looking at is your motor. So bulk, if it's early, it could be normal, but over time, so it's someone who, the natural progression of DMD, they become very, very thin, very atrophied over time. The tone, usually normal, but then with atrophy, if they're not stretched and exercised regularly, then they become very hypertonic, spastic with contractures. And I have a short video kind of that shows the evolution of DMD. Strength, as mentioned, starts off with proximal weakness, and then it can progress. And most kids, if untreated, are wheelchair dependent by 13 years. Sensory is normal. Reflexes can be normal early on, but then as you lose your muscle tone, as you atrophy, then you can lose those reflexes over time. And then the gait, again, because of that weakness, you start to compensate and you start to have this waddling gait, which you'll see here on a video. So these are just examples of some of these findings. So right here is an example of calf pseudohypertrophy. So basically what happens is you have muscle breakdown, and in place of that muscle is fat. So basically you have this fat deposition right here. This is a natural progression of what DMD patients look like over time. So this is toddler age, and then as they get older, you see that formation of that lordosis as they compensate for the weakness in their hips. And then as that gets worse, then they're trying to compensate by even going on their toes. And then this is an example of Gowers, which is basically if you have them sitting on the floor, cross-legged. I usually sit on the floor with my patients so that they're not alone. And then we go ahead and we try to see how they get up. Okay, so here is a video. Hopefully this will play. Oh, never mind. Okay, never mind. It won't play. Okay. So natural prognosis. So it is a life-threatening due to heart and respiratory problems. Again, you're wheelchair bound by by 12 to 13 years of age. And the natural life expectancy is early 20s to 30s due to the heart and respiratory issues over time. So how do we diagnose it? So initially, as we mentioned, we do those labs, right, looking for elevated CK injury. And so it actually peaks by 2 years of age. But if you're not seeing symptoms at 2, you may not see that. So for our patient, it could have been significantly higher than the 17,000. As the disease progresses, your CK levels actually decrease because that muscle is being replaced by fat. And then if you're an asymptomatic carrier, you can actually have elevated CK as well. Aldolase, another marker, as well as your LFTs are also elevated. So gold standard back in the day was muscle biopsy. So back in my day when I was in medical school was a muscle biopsy. And so here's an example of those slides. So you have this nice pink healthy skeletal muscle right here. So it's nice and full. And then you have this degenerated, very thin muscle fibers on this side. So you see these myopathic changes. You can do an EMG nerve conduction, but initially if the symptoms are early, if you catch it early, you may not see that. But then over time, the more of this you have, the more myopathic changes you'll see on EMG. So now the standard practice for diagnosing is actually genetic testing. And this has become very helpful, especially in the last 10 years, because it helps determine if certain patients are amenable to certain treatments, which has made a huge change in the DMD world. Okay, so going over the genetics. So as I mentioned, your dystrophin gene is one of the biggest. It's made up of 79 exons. This is what we call the deletion hotspot. So a majority of patients usually fall within here. So looking at your dystrophin, so you have your 79 puzzle pieces, if you will, or like a train kind of just connected all together. So when all of these pieces fit together, you produce beautiful dystrophin protein, your muscles are normal. When you have a lack of protein, so let's say you have a deletion or an insertion, a duplication of sorts, then those pieces don't fit together. When these pieces don't fit together, then you can't make dystrophin. You can't make dystrophin, you don't have normal muscle. So the majority, as I mentioned, so these are all the different deletions or duplications that we can see that can be amenable to what we call exon skipping, which I'll get to in a little bit. But 72% of patients are due to large deletions, and then 7% around large duplications, and then 20% are other, which is our patient who only had that one pathogenic mutation in that one exon. So the treatment options for DMD. So this is just a nice schematic of what we typically have for these patients available as of at least right now. So the big one that we see is corticosteroids, and we'll go into the different types that we have, but it reduces inflammatory infiltration, sarcolemmal repair, reduces muscle fiber atrophy and lipogenesis. We have gene replacement therapy, which has been very exciting and very new in the world. We have exon skipping, and then right now genome editing, which has not really been approved yet. And then we also have stop codon read-through, which is basically what my patient has. He has a stop codon read-through. All right. So before I get into the types of treatment options that we have, a lot of these treatment options and reason for FDA approval are based on a lot of the, of course, tests, and not only just how they maneuver, but there are specific things that we look at. So there's time to stand. So literally from laying down supine to them standing up. So supine to stand, sit to stand. How long does it take for them to just climb 4 stairs? How far can they walk with 6 minutes? And then what about with 10 minutes? And then we have a North Star ambulatory assessment, which is a 17-point assessment, which is basically this. So we have them stand, walk, stand up from the chair, stand on one leg, on each leg, box step on each leg, not only going up, but also going down, lifting the head. So over time, a lot of these patients lose that muscle ability to lift their head and hold their head up. Standing on their heels, jumping, hopping, and running is the last one. And so so we actually kind of going back earlier to, as I mentioned, when I had a similar presentation. So we did a couple years back, introduction to our neuromuscular clinic, and that was myself. It was Dr. Miner from pulmonary, Dr. Bugnes from cardiology, and now we have involved Dr. Backvale from physical medicine rehab, along with our wonderful rehab team, which is our PT, speech, and OT, and they do a lot of these assessments during our clinic, which is wonderful. So the historical treatment, as I said, is steroids. These are the mainstays, so prednisone or prednisolone. Again, it helps improve your muscle strength and function. It delays that loss of ambulation, so not by a lot, but ideally, you're not wheelchair bound by the time you're 12 or 13. And it also helps delay the onset of cardiomyopathy, respiratory issues, and orthotic issues. You can do a daily dose or high dosing. So daily dose is 0.75 mg per kg per day, and then you just do high dosing on Saturday and Sunday. But as we know, side effects are a huge thing with chronic steroids, because this is lifelong for these patients, right? So they can have weight gain, they have the Cushingoid appearance, excessive hair growth, behavior issues, osteoporosis, delayed growth in puberty, stomach issues, cataracts, elevated BPs, testosterone issues, diabetes or hyperglycemia. So there's a lot of things that coincide with having these chronic steroids. So how do we manage these side effects? So we always have the option of changing the steroid, but that didn't happen until around 2016, 2015, so in the last 10 years. We didn't have any other options, but now we do, which is wonderful. We can change the prescribed dose, but we also have to weigh the risks and benefits of if we decrease it too much, is it going to be effective, right? And then we can change the dosing schedule, going from daily to weekend dosing. But be mindful that with weekend dosing, it's a much higher volume that you're giving the patient. If it's a 5-year-old who hates taking medication, it's going to be a battle. So a lot of things coincide with how to manage the side effects, but also get the patient to take the medication. As I mentioned, a lot of these treatments that I'm going to be talking about only happened in the last 10 years. So deflazacort was the second steroid that was approved. It was approved in February of 2017. Initially, it was only approved for patients 5 years and older, which was unfortunate because there were a lot of patients 2 to 3 years of age who had the diagnosis. And in order to be in certain clinical trials, you actually had to be on steroids for a while before you could participate in those clinical trials, which kind of was a loss for some of those patients. But luckily, in June of 2019, they were able to expand it to the younger age group. So it's a derivative of prednisolone. So it leads to a different chemical structure. So here, prednisone and prednisolone. So this is going back to OChem, which I'm not a fan of, but it has the 4 rings here. And then you have your deflazacort, which has the 5 rings. But because of this chemical structure difference, it can explain some of the differences in the pharmacokinetics, the pharmacodynamics, leading to lesser side effects. For the same as prednisolone and prednisone, you can do daily dosing or high weekend dosing. And we have to put max, dosing. We do have patients who are on the obese side, and if we give them too much, then of course we have more problems. So they have a max recommendation. So the key differences between deflazacort or Emflaza versus prednisolone is lower lipid solubility, so it doesn't cross the blood-brain barrier as much. So then we see lesser behavioral side effect profile, less effect on glucose metabolism, and because there's really little to no affinity for the mineralocorticoid receptor and the active metabolite, then it's less potent overall. So the biggest things that we always tell patients between the two is that it's still either daily dosing or high weekend dosing, but the side effects may be a little bit lesser. But again, every patient is different, right? So it could still be pretty significant for the family. So one of the newest ones that was just approved in October of this past fall, October 26, 2023, is Agamree or vamorolone. It's a dissociative steroid, which is the first of its kind. So it binds to the same target receptors as the corticosteroids, but shows a distinct chemical structure and difference in the mechanism of action. So like the traditional steroids, which helps to decrease inflammation, and steroids decrease inflammation by inhibiting your NF-kappa B activity. So the Agamree also inhibits that, but unlike the traditional steroids, it reduces the activation of other response elements. So it has even minimal side effects. At this point, I personally don't know. None of my patients right now have transitioned to Agamree yet. Some of them want to, but some of them are hesitant because they've been on the other steroids for so long that they don't want to see a change. But it is an option that we can always give to patients. So again, still very new, so really not a whole lot of information long-term yet. It's orange flavor suspension, so there is no pill form yet. So for a lot of other patients who don't like suspensions, it's also an issue. But this is more of a daily dose. I haven't seen anything for high weekend dosing as of yet. And so basically in a study in a 24-week clinical trial that included 121 boys with DMD ages 4 to less than 7, they gave a placebo to 30 boys, Agamree of the higher dose, 6 mg per kg per day, to 30, the lower dose of 2 mg per kg per day to 30, and then prednisone of the standard 0.75 mg per kg per day daily dosing to 31 patients. So their primary outcome, as I mentioned, all those different functional tests that we look at, was their time to stand. So the speed was faster with Agamree versus placebo. With a higher dosing, it was fast. It was at 0.6 rises per second faster. And then for the lower dose, it was 0.05 rises per second faster. So anything over 0.02 rises per second was a clinically important change. Some secondary endpoints that they looked at, was the 6-minute walk test, as well as the time to run / walk 10 meters. So for the 6-minute walk test, they walked 42 meters farther with a higher dose and 40 meters farther with the lower dose. Anything greater than 28 to 32 meters was of a clinical important change. With the time to run walk 10 meters, 0.24 meters per second faster with a higher dose. I didn't see one with a lower dose. Again, a lot of these data points haven't actually been published yet. I mean, it's published, but it's still in the works. But anything over 0.2 meters per second was a clinically important change. And then they looked at certain safety measures in regards to steroid dosing with AGAMREE, and then that's when the prednisolone group came into play. So they looked at growth and behavioral problems for these patients. So they noted that after 24 weeks of treatment, boys treated with AGAMREE, both at the higher and the lower dose, had an increase in height percentile compared with a decrease in height percentile in boys treated with your typical steroid. And there's not associated with a mean reduction in biological marks of bone health. And they also saw less behavioral problems over those same 24 weeks as well. So that was one of the more exciting things. And there was a recent Parent Project DMD conference where they did more information. So hopefully we'll get some more data and more information, especially in regards to other systems, cardiology, pulmonary, and things like that over time. So the next thing that we're going to talk about are the exon skipping therapies. So this again has been in the last 10 years. I believe the first one was approved in 2016 or so. But it helps to restore that reading frame. So as I had shown you earlier, those puzzle pieces that fit nicely together, when something is deleted, those pieces don't fit together. But what these do is they take out whatever is blocking the pieces to fit together, which I'll show you a picture here in a little bit, and it restores that reading frame. So there have been 4 that have been FDA approved. There's eteplirsen or Exondys 51, and these numbers show you which exon that they're playing on. Golodirsen or Vyvanse 53, Viltepso or Viltolarsen, which also acts on exon 53, and Casimersen, which is Amondys 45. So I didn't look up the other prices, but as you can tell, they're not cheap. So how does it work? So as I mentioned, so let's say you have a deletion right here, right? So you are not making your dystrophin. So basically what you want to do, you want to fit 48 and 52 together. So then you take out 51. And so that's what eteplirsen is. It is Exondys 51. So it takes out 51, restoring 48 and 52 together, allowing the body to make dystrophin. So these are just some studies. I'm not going to go into the specifics, but so for all of these, they actually looked at the muscle biopsies to see how much dystrophin has increased over time. So this one, they looked at 12 boys, and each one showed increased dystrophin over the 48 weeks when they looked at the Western blot of the muscles. Same thing with Vyvanse 53, and a lot of these all have the similar side effects. Fever, high skin irritation, pyrexia, URI symptoms, kidney damage as well. And this one looked at 25 boys and over 48 weeks also showed increase in dystrophin when they did the Western blot. Same thing with Viltepso, same side effects as well. They looked at, so this one increased by 5.9% over the 24 weeks of having these patients. And this one, I have listed their secondary endpoints here as well. So same things that we looked at before: time to stand, time to climbing the 4 stairs, the 10 meters, and the 6-minute walk, as well as your NSAA. And then same thing with Amondys, showed an increase in 1.744%. And this was over a 48-week study. So the last time I gave this talk, the biggest thing was this gene therapy study called EMBARK. And this was in 2021. And since then, it has been approved this past summer, June 22nd of 23. So it's called Elevidys. It got accelerated approval by the FDA. as it is considered reasonably likely to predict a clinical benefit for these patients because the elevatus microdystrophin was noted to be increased in these patients. So it is very limited to who can get this. So same thing with the exondys. So again, you have to have specific deletions in order to be able to be amendable to those exon skipping therapies, because not everyone can just skip exon 51 or exon 53. For this one, it's based on age. So right now, it's only approved for ages 4 to 5 years of age with a confirmed mutation, but it also has contraindications to specific mutations. So what is Elevidys? Elevidys is an adeno-associated virus-based gene therapy. So basically, it addresses the root genetic cause of DMD by delivering a gene that codes for a shortened form of dystrophin, known as the Elevidys microdystrophin. So instead of the larger regular protein, you have only 138. So basically, what they do is they take the adenovirus vector, they insert that microdystrophin, and then you have a single infusion, a one and done infusion in the through the peripheral. It approximately takes 1 to 2 hours to run, but the visit may be a full day just to monitor. Quite expensive at $3.2 million per infusion. So again, unfortunately, not all patients are candidates. Individuals with any deletions in exon 8 and or 9 should not receive it. And the reason is that what they have seen is that the people who have this type of deletion may not have ever made that part of the dystrophin protein for which the adenovirus vector is holding. So when their body sees that microdystrophin, then it may consider it foreign and then attack it, and then you can have a severe immune response to it. And then you can also have other side effects as well, difficulty breathing, myositis. They also showed maybe some increased risk for some severe immune-mediated myositis with these specific deletions as well. And so right now, again, because it was accelerated FDA approval, they still have to complete more clinical studies to confirm the drug's clinical benefit. But for right now, they have looked at the time to rise and the North Star ambulatory assessment. And so they were able to improve both on these, especially with this NSAA over a 52-week period, improved by 2.6 points in comparison to 1.9 points in the placebo-treated patients. So there are currently, as of the summer, there was more than 140 boys treated with Elevidys. We have one patient who does qualify. He's 4 or will be 4. And so we are hoping to get into the works for that. It was already addressed over the summer, but there's a lot of paperwork and things that get into it. Unfortunately, our other patients are older, so they were not able to qualify for this. So these are the current studies that have been going on with Elevidys. So they looked at different ages, so 3 to 18. So each one is looking at different age groups right here. So I'm not going to go into the specifics for that. Biggest side effects are vomiting, nausea, acute liver injury, pyrexia, and thrombocytopenia. And then, of course, immune-mediated responses. So because of that, just like gene therapy, so similarly for spinal muscular atrophy, there's also a gene therapy for that called Avexis, and it's a similar type of pre-infusion and post-infusion type of treatment. So again, because it's an adenovirus vector that is being used, we have to check your antibody titers. Unfortunately, if your antibody titers are elevated, then you are not eligible to get the treatment. Reason being is if we introduce that vector to you, your body may attack it and you have to go into your immune response, severe immune response. And so unfortunately, that could also be a rate limiting factor. Your liver function and platelet count and troponin levels are also checked prior to. And you also have to receive steroids to help decrease that immune response from getting this gene therapy. If you're already taking steroids, then there are specific parameters that we use. If you're not taking steroids, a different set of parameters, which I'll get into. But you do need to be on steroids for at least 2 months after infusion, and this is in addition to your steroids that you're already taking. So families just have to be mindful that now there's going to be an increase in any certain side effects during this process, especially at least for probably 4 months, because you have to be monitored 3 months after the infusion. So the corticosteroid regimen, so they use prednisone or prednisolone. Right now, deflazacort is not recommended because Agamree is so new. I didn't see any information about if Agamree would be able to be used. I'm assuming not. But baseline corticosteroid use, if you're already on it, is 1 mg per kg per day in addition to your typical dose. And then based on high dose, if you're doing that just on the weekends, they also talk about just adding the 1 mg per kg per day on the days without your high dose. If you're not on steroids, which most patients should be on steroids, all patients should be on steroids, you just start at a higher dose and 1 week prior versus 1 day prior. So post-infusion, so again, as I mentioned, for 3 months, they're going to monitor your LFTs, weekly blood tests for 1 month to monitor your troponin, and platelet counts for 1 month weekly for the first 2 weeks. So a lot of these patients fall into the age group where they're supposed to get their vaccines, right? So we have to try to make sure that they get their up-to-date vaccines at least 4 weeks prior to the steroids. That's required before receiving a Levitus. And then, of course, hand hygiene. Sorry about that. Okay. All right. So, okay. Sue warned me about this little controller. Okay. All right. So that is one of the most exciting ones. And again, the PPM Parent Project Muscular Dystrophy Conference just happened. So there's a lot of more clinical trials in the books. And so it's just really nice to know that there's a lot of research going on, not only for your restoring your replacement of the dystrophin, but looking at fibrosis, regulating calcium balance, restoring the cell energy and improving heart function, which is fantastic. But overall, it's a multidisciplinary team that helps monitor these patients because not only do they need neurology, pulmonary, cardiology, PM&R, but you also need endocrine, ortho, ophtho because they're at risk for cataract. So it's a whole team, including your rehab members that help really care for these patients. So this is just based on an article back in 2017 of an example of how often we see these patients. And one thing that I also did not mention, which is very important, is genetics as well as psychiatry. So they see genetics initially, of course, at their diagnosis, psychiatry and neuropsychology, especially if there is underlying cognitive issues as well. And then you put them on chronic steroids and it just makes it even worse. So we usually have them involved. For those who are far off already, we try to have palliative care involved. But that is it. These are my 2 twins. So yeah. But yeah. And on a fun little note.
Oh. All right. Do we have any questions from audience members? Raise a hands.
Hey, Dr. Mattson, before we hit the Q&A, and thank you so much, Dr. Reyes. I was getting bombarded with emails and phone calls up in my office. The instructions that I sent for Cloud CME, it does work, do everything on it. There was a technical issue with Wright State on their end. Somehow the credentialing they had, it's set for physicians only. So nurses and non-physicians were not able to find to record their 195 session. So try it again. And again, you get 2 hours after grand rounds. So play with it if you have any other problems. But I did want to give you this update right now since I just got off the phone with Wright State. Yes, sir. What is the number? Or ma'am, I'm sorry. What is the number? The session is 195. Uh-huh. Now we played with it upstairs with Wright State and it did show up. I went to the home page. I went to the My CME. I went to evaluation and certificate box and it showed up with today's date, of course, 131. So, okay, a little bit of a success with it, right? I'll turn Q&A back over. Thank you, everyone.
Okay, any questions from the audience? Okay, I got a question from Lubna, and it's more regarding the right state issue. It says, is the session going to be called 195 every single week? Or, okay, it will change every week. Okay. But they can't hear you.
Getting his steps in.
Mine was kind of a really specific question. For one of the studies, I can't remember which medication it was, but they had the corticosteroid group, the 2 dosing groups, and then a group that was on no medication.
For a gamma, yeah.
Yeah.
So,
And I was just curious about like the ethical considerations of having a group on no meds at all, given we know the benefits of corticosteroids, and just if they talked about that during the study at all.
yes. So unfortunately, I don't know how they go about talking about that amongst the research team members. I apologize. These clinical trials are not, I'm not involved with all of that, but there are ethical issues as I'm aware of. I just don't know how it's addressed. I apologize. Yeah, but great question.
Given that the life expectancy is only 20 to 30, have any of the new clinical trials that we've looked at, I see all of them show improvement in maybe quality of life and muscle bulk, but do those affect the life expectancy? And how soon do you think like palliative should get involved, given that the life expectancy is only in the 20s?
Yeah, no, great question. So kind of just taking a step back. So I guess starting with the wheelchair, natural progression is wheelchair bound at 12 or 13. So a lot of our patients who are on these treatments have delayed, have a delay in that, right? So they're ambulatory longer. We have maybe, I think, one patient who's in their early 20s. But again, a lot of these studies are relatively new, right? So if it was only started in the last couple of years, we don't really know. But my understanding, at least from what I've seen, because they're looking at 18-year-old patients right now with this gene therapy, is hoping that they live into their early 20s, 30s. In regards to palliative care, when do we get that involved? I certainly get them involved when it's patients who don't want to do any treatment. So there are patients who would rather not do treatment, not do steroids, not do anything. And that is unfortunate, but so for those patients, I get palliative much sooner. It is something that I always talk about in the early beginnings when I diagnose a patient with DMD, that is an option. If at any point in time we see that they are progressing to the point where it is affecting quality of life, they're becoming cachectic, they're unable to do a lot of their own things, then I involve palliative if family is agreeable to it.
And Dr. Cook from our palliative care team actually weighed in and said she would ideally be involved at diagnosis.
Yes.
So,
Yeah. Mm-hmm.
Any other questions from the audience? All right, I think we're done.
Well, thank you guys. Thank you. Thank you, Dr. Madsen. Love the costume, by the way. Sorry I didn't partake in this scene right here. I was debating. I was like, I could be at the podium dressed up as something.
I tell you, it gets really, really warm in
I
there.
was gonna say,